tanks to complain that this isn't enough. Well, one of the luxuries of leading a think tank is that you don't have to engage with the choices and trade-offs that government does. The Chancellor had to raise more than £40 billion to plug not just the £22 billion hole we walked into in July, but also to fix the foundations so that our economy and our public services can recover from years of mismanaged decline. When the Chancellor announced the settlement for my department, she joked about how unpopular it would make me around the Cabinet table. And the truth is, at the Cabinet meeting in which she set out the contents of her budget, I did feel uncomfortable. Not because I was worried about the opinions of the people in the room, because they support the NHS and the investment, but because I am worried about the jobs they have to do. As I look around the Cabinet table, I see a Justice Secretary who inherited overflowing prisons, a Work and Pensions Secretary who inherited more than 4 million children living in poverty, a Defence Secretary charged with securing our nation at a time when there is a ground war in Europe, as well as constant and emerging threats of cyber warfare in a more dangerous and unpredictable world. So every penny of extra investment that goes into the NHS was a penny that didn't go towards child poverty reduction or extra prison places or bolstering our armed forces. And more than that, every penny that's spent on treating sickness is a penny that doesn't go on preventing illness. And you know as well as I do that around only 20% of the nation's health is affected by the NHS. The rest is dictated by the poverty we live in, the damp on our walls, the food we eat, the air we breathe, and so on. So you can't pretend to care about the social determinants of ill health if you only ever ask for more money for the NHS. So then, the argument goes, we must do both. And of course, that's right. But the choices and trade-offs aren't just about spending money, but raising it. The tax burden in this country is at record levels. We chose, rightly in my view, not to hit working people in their pay slips. The extra investment in the NHS, as well as other public services, meant asking employers and the wealthiest to pay more. And you'll have seen in the past few weeks that there are those who disagree with the Chancellor's decisions, and that's the nature of tough choices. But we stand by our decision to prioritise the health service. Healthy businesses depend on a healthy workforce, and a strong economy depends on a strong NHS. But if you want to know where the average taxpayer stands on NHS spending, it's quite straightforward. They welcome the investment, but they worry it won't be spent wisely. They agree with the central argument we made at the last general election, that investment must be matched with reform. We entered government with the public finances and the public services in a far worse state than they were when Labour last went from opposition to government. Tight fiscal constraints mean that reform needs to do a lot more heavy lifting. But even if we'd inherited the strong economy and public services we saw at the height of New Labour, we would still need to reform our public services, because we're standing in the foothills of a scientific and technological revolution that is changing the world around us. Citizens are used to choice, voice, ease and convenience at the touch of a button. We expect everything faster. Unless our public services are modernised to meet the needs of our people, they'll become increasingly redundant and irrelevant to people's lives, unable to meet their needs. The failure to reform the state to meet the needs of the people is one of the fertilisers of populism we see across liberal democracies. The other is a failure to ease the pain in their pockets. So we need to address both, with NHS reform that delivers better outcomes for patients and better value for taxpayers' money. By now you'll be familiar with the three big shifts that will underpin our 10-year plan for health, from hospital to community, from analogue to digital, from sickness to prevention. These shifts are not radical new ideas, but delivering them truly would be. They're necessary to tackle the challenges of our growing ageing society, rising levels of chronic disease, and rising cost pressures, as well as to seize the opportunities of a scientific revolution in which AI, machine learning, genomics, and data offer us the chance to transform our system of healthcare to one that can not only diagnose earlier and more accurately and treat more quickly and effectively, but also predict and prevent illness. But we're not waiting for the 10-year plan in May to get cracking with reform. Over the last few years, I've regularly heard the criticism of the top-down nature of the NHS. It can be a difficult criticism for those at the top to hear. But for the last 4 months, I've found myself at the top of the system, at the peak of the mountain of accountability. And I not only recognise the criticism, I agree with it. The NHS in 2024 is more hierarchical than almost any other organisation I can think of. Even our armed forces, as the Messenger review argued, are less locked and centralised into command and control. Those of you who have studied the birth of the NHS will know that there were vigorous debates within the Attlee government about how the new NHS should be organised. Given the vital role that a strong state and central planning have played in Britain's success in the Second World War, it was perhaps inevitable that Nye Bevan's centralised model won the day, albeit with some concessions to the doctors to overcome opposition from the BMA. But Herbert Morrison and others in the Labour movement had argued strongly for a municipally based model with power and control exercised locally. Attlee and Bevan could scarcely have imagined in 1948 that the single-payer system they created would make the NHS ideally placed to seize the opportunities of data, genomics, AI and machine learning. The N, the national, in NHS is important. It should be the guarantee that patients everywhere are treated according to the same values and the same standards. When we were last in government, we recognised that not everything could or should be run from the centre. New Labour's reform agenda created foundation trusts, increased patient choice, and used financial incentives to raise performance and increase transparency. In doing so, they oversaw dramatic falls in waiting times and increased public satisfaction to the highest levels on record. I really can't explain what happened in the next 14 years, but I hope that someone somewhere is writing a PhD on how it was that a party of the right, setting out to liberate the NHS, ended up with far more centralised control and far weaker public accountability. But the legacy of their botched reforms we are living with. It's been mismanaged decline and a confusion over who is supposed to be doing what in the system and an absence of any governance philosophy. The framework I'm setting out today is based on triple devolution, with power shifting out of the centre to ICBs, to providers and crucially to patients. I want to lead an NHS where power is moved from the centre to the local and from the local to the citizen. Morrison meets Bevan. It starts with clarity. The centre should be deciding strategy, policy and clear objectives for the system to deliver on behalf of patients. We should allocate resources against those objectives and provide the overall accountability framework for improving performance. We should ensure the same standards of care in every part of the country, and we should unlock the unrealised potential of the NHS as a single-payer model by making the NHS the best partner in the world for the development of new treatments and medical technology, and to make the most of our collective purchasing power to deliver value for money. And the centre should be smaller. As power flows from the centre over time, resources should flow with it. Otherwise, it will keep swamping local services with diktats and demands that distract them from the job of meeting patients' needs and improving the communities they serve. We need more doers and fewer checkers, and the centre needs to learn the words stop and or after years of start and more. Clear priorities mean a few, not 50 different targets, so the instructions coming out in the forthcoming NHS mandate and the following planning guidance will be short. I want to see waiting times cut, urgent and emergency care when people need it, and improved access to primary care. The shift from hospital to community needs to start now. Amanda set out yesterday that NHS England, not ICBs, will be responsible for managing performance of trusts. When I talk to ICB leaders, I hear mixed views about where they should be focusing their efforts. There is no uniformity and too much confusion. So let me be clear. I want to see local commissioning back, and I want to see ICBs leading it. ICB chiefs, I'm talking directly to you. You will lead the transformation of care, the pioneers of reform. Your organisations will play a critical role in doing what we've never pulled off before, shifting the system left. I want ICBs to focus on their job as strategic commissioners and be responsible for one big thing: the development of a new neighbourhood health service. It will focus on building up community and primary care services with the explicit aim of keeping patients healthy and out of hospital, with care closer to home and in the home. All the evidence suggests that 1 in 4 patients in hospital should not be there, and that 1 in 5 emergency hospital admissions are preventable so long as earlier diagnosis takes place. So there's your challenge. We need to design services around people, particularly more than 15 million people with long-term conditions who are too often passed from pillar to post, from one service to another. Fragmentation needs to give way to integration, and that is the job of integrated care boards. That will leave providers, whether NHS Foundation trusts or regular trusts in mental health, community or acutes, to get on with the job of improving frontline services for patients, including restoring the 18-week waiting time standard. Over the past decade, provider freedoms have been curtailed. I view that as a retrograde step. Starting with the best performing trust, providers should be given greater freedom and flexibility to innovate, run community services, and manage their own house to meet the needs of their patients. The last Labour government had a philosophy of earned autonomy. I want to go further and faster than my predecessors did. Our long-term ambition is that all providers should enjoy the same freedoms as foundation trusts, so long as they deliver improved performance. And critically, those ICBs that perform best, particularly in developing neighbourhood health services, should also enjoy greater freedom and flexibility. We will no longer treat all providers and ICBs as if they are all performing equally, when you and I know it's a mixed ability class. We'll assess systems against a set of criteria and publish the results starting from next year. Those systems and providers that are in the middle of the pack will get support to improve, to bring them to where the best are now. Those ICBs and providers that are doing well will be rewarded with greater freedoms over how to spend their capital, with fewer ring fences, for example. Those that demonstrate the best financial management will get a greater share of capital allocation. We want to move to a system where freedom is the norm and central grip is the exception to challenge poor performance. So improving services for patients should be rewarded, and the quid pro quo is that there will be no more rewards for failure. The work you do couldn't be more serious. When you get it right, lives are saved. When you don't, the consequences can be tragic. If performance dips, I reserve the right to take those freedoms away, and for those judged to be persistently failing, we will act, going from 0 consequences for failure to 0 tolerance. Our new pay framework for very senior managers, which I know has been long awaited in the system, will be published ahead of the next financial year and will set out substantial reforms. It will drive consistency, increase transparency, and limit VSM pay inflation, whilst giving sufficient flexibility to attract talented candidates to the most challenging roles and providers. It will also ensure that those who are in charge of organisations that persistently fail to provide decent care or fail to keep a grip on their finances do not receive annual pay uplifts. Failure to have appropriate regard to the framework will be considered a governance issue and therefore be backed by the full range of regulatory levers at NHS England's disposal. Failing ICSs will not have access to capital flexibility, and neither will trusts, including foundation trusts that have the badge but don't meet the mark. Turnaround teams will be sent in to diagnose the problem and help fix the problem. Financial controls will be imposed if necessary, and where leadership is found lacking, they will be removed. Now, given the performance of politicians in recent years, you might think it's a bit rich for a politician to be stood here telling you about leadership. But there's one thing I'm sure of after the last 4 months. One person behind a desk in Whitehall cannot deliver the mammoth task ahead of us. Taking the NHS from the worst crisis in its history and making it fit for the future will require first-class leadership at every level of the system. The journey of reform is one I'm determined to take with you, not impose upon you. And that's where you can expect a break from the past, a grown-up break from the past. No more manager bashing for manager bashing's sake. Lord Darcy's investigation into the NHS concluded, and I quote, that the problem is not too many managers, but too few with the right skills and capabilities. And let me tell you, that is not the most convenient conclusion for a politician to receive. I could be no more popular than announce the sacking of lots of managers. But that would not be the right thing to do. And I'm prepared to make an unpopular argument with the public about the value of good leaders. The NHS is one of the biggest organisations in the world. We should be competing with global businesses and public services to attract top talent. And for that, we need to attract and retain the best. So we will invest in you and support you. Yesterday, Amanda laid out our plans to develop a new NHS management and leadership framework with a single code of practice, set of competencies, and national curriculum to help develop essential leadership capabilities. And today I can announce that we're establishing a College of Executive and Clinical Leadership to help train and develop excellent NHS leaders. Non-clinical leaders should be working in lockstep with clinical leaders, and that's why I want this resource to be available to every type of leader in our NHS. And I've asked Sir Gordon Messenger to help us develop and attract the talent we need to develop our 10-year plan. The most important person in all of this is the patient. Since we launched the national conversation on the future of the NHS with the Prime Minister a few weeks ago, I've been struck by how loud the patient voice has been during the exercise. It's almost the inverse of my experience in my average working day. Popular and familiar ideas, like allowing patients to choose where and when to be treated, making it easier to rearrange appointments, and grouping tests and scans together in one visit to save time, rarely pass the lips of most of the people who walk through my door to say something to me. I said in opposition I would be the patient's shop steward. Now I'm in government, I'm here to be the patient's champion. They will be at the heart of the 10-year plan next year. Their priorities will be reflected in a new NHS mandate shortly, and when the elective recovery plan is published in the coming weeks, you'll see that greater choice and control is at the heart of it. We start from a low bar, and we're not going to change the experience overnight, but the direction is clear. Patients should be able to choose where we're treated and when. The ease and convenience with which we organise most of our lives and the best performing providers allow us to organise our healthcare should be available to everyone in every part of the country. That's why I welcome Amanda's announcement yesterday about the new ping and book service for breast and cervical cancer checks. Power to the patient is my mantra, and it needs to be yours too. Finally, right now I know that many of you are feeling bruised and battered. 14 years of austerity, a global pandemic, and no political direction has taken its toll on everyone working in the NHS and social care system. I know it won't be easy to turn the tide, but my message to you today is a message of hope. The Prime Minister pledged the biggest reimagining of our NHS since its birth, and it falls upon all our shoulders to deliver this, the jewel in the crown of this government's decade of national renewal. The challenge is huge, but the prize is enormous, and the change has begun. The package of reforms I've announced today is how we'll get more out of the NHS for what we put in. This is how we make sure the investment announced in the budget delivers real change for patients, and this can only be a team effort based on a shared national mission to recover and renew our national health service. You have dedicated your careers to public service, and I know that among you I'm not alone in the scale of my ambition. To coin a phrase, we are in this together. The NHS is already living on borrowed time, and if a Labour government can't improve the NHS, then it simply won't survive. But if we get this right, we can look back on our time with pride and say we were the generation that took the NHS from the worst crisis in its history, got it back on its feet, and made it fit for the future. Many of you in this room have done it before. We can do it again. Thank you very much.
Thank you, Minister. Before I take questions from the audience, I've got a couple of questions for
you.
There have been league tables before and they were scrapped. How will these be different? And are they just a gimmick that won't tackle deep-seated, complex problems?
I would take that criticism if it was the only thing we were talking about today, and if it wasn't part of a much wider package of greater freedom, autonomy, freedom to innovate amongst high performers, and a whole range of support for the middle of the pack, and a recognition that for people in the most challenged systems, we're going to look at a range of contextual factors. I think it's, if I think back over the last 20 years or so of our experience of healthcare in this country, and you look at the systems with the poorest performance, even when the NHS is performing at its best, tends to be the same areas. So I recognise in those parts of the country that there are wider systemic challenges that we need to be alive to, and which, frankly, the NHS is well equipped to understand. The regions are well resourced, my department knows where those challenges are, and we need to get the best leaders into those areas to help turn them around and to deal with some of the underlying factors. But when it comes to poor performance, and I know people have seen some of the headlines and bristled, I think it is really important that as we try and rebuild the NHS and rebuild public trust at the same time, that we are really honest and unequivocal about the guilty secret of poor performance amongst NHS senior leaders, which is, it is entirely possible. Indeed, I have seen it happen, if I think about some of the people who've passed through my own trust, that someone who is known to be a poor-performing senior leader is quietly brushed aside, sometimes with a golden goodbye, and then magically reincarnated somewhere else, leading some other poor trust. And that has got to stop. And to people who bristle at the headlines and think, oh my goodness, is this about attacking all managers? Absolutely not. It's about weeding out the rotten apples to make sure that the excellent leaders are not tarred with the same brush. And if people don't think that good leadership makes a difference in poor areas, come and visit my local trust, Barking, Havering and Redbridge. For years we were known as a troubled trust. We were in and out of special measures. I'm in polite company, it's before the watershed, I won't tell you what my constituents said about our local trust. In Matthew Traynor, we have an outstanding leader who has built a really strong team of clinical leaders right down to the front line, one of the fastest improving trusts in the country, and some of the work that his team are doing, empowered by his style of leadership, is some of the nationally leading work on things like busting through the backlog. So good leadership matters, transparency matters, and that accountability matters, especially when you think about the life and death public service that the NHS is. So I hope that today, people think we've got, you can challenge me because you're here, but I think we've got the balance right on the kind of accountability and performance management side, but also I hope I'm not just taking you with me, I hope I'm following the direction that you've set for me in terms of letting go of control from the centre, setting people free to innovate, to be great leaders and providing the support to equip you to do that.
Thanks. We know there's a rising demand and long waits for mental health care. We also know there's a lack of robust data when it comes to mental health services compared to physical health services. What reassurance can you give the audience that these league tables won't ignore mental health yet again?
Well, it's an interesting question because people can't have it both ways. You can't complain about data transparency and then say we're not including everything you want included. I do think there's an issue about mental health weights and the spotlight we put on mental health, and I'd say the same about paediatrics, by the way. I can tell you on behalf of the Prime Minister, he was pretty stunned on a visit here in Liverpool to go to Alder Hey, meet some of the brilliant clinicians working there, but also some of the national clinical leaders in NHS England who were sharing their frustration that paediatric care is not given the spotlight and focus and attention that it deserves. So I think, and taking on board my own kind of self-restraint here, about not kind of imposing loads of targets and weighing down more and more instructions onto you, I think the conversation we're having now and the conversation we have in the coming weeks and months will be really important for boiling down the key metrics that we want to put in the spotlight to improve patient care and to give you clarity of direction from the centre, so you're not being pulled in a million different directions by different people at different levels of the system, because I recognise from talking to many leaders how frustrating and actually how counterproductive that has been.
And this brings us to probably the most common question on Slido. What about social care? Where does that fit into these league tables?
Well, look, social care is important in and of itself. It's a public service in its own right, and it's important for the freedom, dignity and independence of older and disabled people. It is also integral to the success of the NHS, and I recognise that social care has been the poor relation to the NHS. It goes back to what I said in my speech about choices and trade-offs, folks. There'll be lots of people at the moment who are looking at the NHS settlement and thinking, oh, there are going to be some choices for us in the system here, and there certainly will be. But you've got to recognise the choices and trade-offs we're making across the board. And on social care, we've already announced a number of steps. There was some specific funding for social care in the budget. There was some wider support for local government. that will help to ease the pressure on public or local government finances overall, that places a particular strain on social care budgets. We've legislated for the first ever fair pay agreements in social care, and we'll be shortly setting out the steps we'll be taking to build the 10-year plan for social care alongside the 10-year plan for the NHS. But while there's an obvious interdependency, and some of the best performing trusts, I think about some of the work that's been done in Leeds, has kind of driven integration of health and social care and built stronger partnerships, I do still think these are distinct public services, and I'm very comfortable with where we are in terms of health and social care, rather than the NHS being a national health and care service.
We need to have some questions from the auditorium, but before that, one very popular comment says, I have no issue with accountability and holding managers to account, but there needs to be a recognition that not all organisations or systems are created equally. It's a very good point.
I absolutely accept that, and that's why I think the approach we're taking of rewarding success and setting people free, and also supporting systems that aren't the leaders of the pack, I think is the right balance, and understanding the contextual factors within a particular system, I think is going to be the approach we take to performance improvement. But we're not just there to kind of observe the state of things, we're here to fix it. And so where there are wider systemic challenges for particular providers or particular systems, let's work together to fix them. Surely in the world of NHS regions, integrated care systems, and a government that wants to drive more power, more autonomy, more resources, more decision makings from the centre to the regional and to the local, and from the local to the patient, we can fix some of those underlying problems. But,
Right.
but they're an opportunity to fix rather than an excuse for poor failure.
Right, questions from the auditorium? Let's go to the front here. Microphone is on its way. There we go.
Thank you, Henry Anderson, HSJ. I wanted to ask what trusts there are where you think there should be a change in leadership because you think they're persistently failing. And if you can't name a specific trust, what areas of the country do you think are failing and where there needs to be a change in leadership?
I couldn't quite hear the question.
What areas of the country do you think there should be a change in leadership in? What trusts do you think are persistently failing?
Yeah, who's doing a good job and who's doing a bad job?
Yeah, well, I've not come along to name and shame today. If people want me to, I'm very happy to. But that's not what I've come here today to do. I've actually chosen to name and praise in terms of my local trust. What we're interested in doing is making sure that we've got clear lines of accountability, transparency, and that we're able to effectively performance manage. And by the way, when I say manage out bad leaders, I'm not in the business of public humiliation, but nor am I in the business of allowing people to be reincarnated elsewhere. So I hope that balance is clear. And people disagree with that, fine, but you should be more angry about the people who give the profession and the service a bad name rather than the people who are trying to fix it.
A question over there, I believe. Yeah.
Yes. Good morning. Eileen Taylor, Chair of East London Foundation Trust and, Northeast London Foundation Trust. Great recognition for BHRUT and the work they're doing in Matthew. But Secretary of State, please, if you could also remember that Northeast London Foundation Trust is also your local trust, and we provide mental health and community health services. And so it would really help with that left shift if you could also reinforce that it's not just the acute trust, but it's the community and mental health providers. Thank you.
Yeah, look, I'm very aware of NELFT, not least because NELFT has and continues to appear in the headlines for providing really poor quality care. So if we want to name and shame, I'll do the name and shaming alongside the naming and praising. I agree with you about the need for the left shift. That is a big part of the government's focus. That is exactly what we want to deliver. But, I really don't need lectures from NELFT about recognising the challenges and pressures there, because I read about them in the newspapers on a regular basis.
Question over here.
Hi, can you hear me?
Yeah, just about.
Rebecca Thomas from The Independent. I'm House Secretary, I'm going to come back to you on mental health, because I don't think you quite set out your answer there on the focus of mental health. The DH hasn't been able to say it would commit to the mental health investment standard. Will you or won't you commit to maintaining that, or will you go a step further, something better? Can you answer that question?
The mental health investment standard is really important. We want to stick with it. We haven't announced allocations over the course of the coming years. We've also got the settlement from the Chancellor, and we've got a clear indication of where we're going over the course of the spending review. Of course, I want to grow mental health as a proportion of NHS budgets. We're also focused on elective recovery. That is really important. It is the #1 priority for the public. It's a big priority for the government, but we want to maintain progress. The fact that we have just in recent weeks introduced the mental health reform bill into Parliament after years of promises and inaction, I think should be a statement of intent. And some of the commitments we set out in our manifesto around mental health, whether support for young people in schools, walk-in mental health services, extra staff for the mental health sector, I think hopefully signals the seriousness of intent of this government. And recognising that we've got challenges at the acute end, we've also got to do more on prevention. Prevention is better than cure. And if I think about children and young people in particular, and the extent to which they're ending up on mental health waiting lists and in real mental health crisis, if we get there earlier, not only is that better for them, it's also a much better use of taxpayers' money.
Okay, final question over there, number 1.
Josh Collins, CEO, 18 Weeks Support. We're an in-source of providing support services to many trusts across country. I wondered what role you feel private services such as ours have in the elective recovery plan.
You know, I've taken on some of the arguments around the independent sector before and since the election. We want to use the independent sector to bring down NHS waiting lists where there is spare capacity and flexibility to do so. Obviously got to get the balance right on things like standards, quality, and also making sure we're not robbing Peter to pay Paul in terms of staffing. But I'm pretty sure with the conversations we're having with the sector and the strategic approach we're taking that the independent sector can add value without compromising on quality, on cost, or the capacity within the NHS itself, and that's the balance I'm determined to provide.
Thank you. Thank you, Minister, for coming today. As a reminder, we'd love your feedback on this session. Please do so through slido.com. It's time for refreshments, so please make your way to the exhibition hall, where teas and coffees will be served until 11:50. The Delivering with Partners sessions will be taking place in exhibition theatres during the breaks. Please do attend these sessions. We will be back in this room at 1:50 p.m. for the closing sessions. Thank you.
Thank you.